Good afternoon, everyone. Good afternoon. How's everyone doing? Good? Wonderful. Well, I'm super excited, to be back with you to discuss program planning, management, and evaluation. I was here a couple of weeks ago before your midterm exam. And by the way, great job on the midterm. That average at least was one of the highest, that we've had in the history of this course. So I was happy for you. Prior to that, we met here and we discussed strategic planning. Does everyone remember that class session? Okay, good. And you will recall that we said that strategic planning is one of the key, functions of public health leaders. And we agreed that strategic planning is as important for public health agencies as it is for private hospitals and healthcare systems, as it is for non-profit organizations. Everyone remembers that? Okay. So just to recap, and again put things in context. So a couple of weeks ago, again during our discussion of strategic planning, we really focused on the 4 key phases in the strategic management cycle. Okay, starting with conducting internal and external assessments of the environment in which the organization operates. And as part of that, we together conducted a SWOT analysis of the MPH program. That was our classroom activity related to that phase of the strategic planning process. We then moved on and discussed the second phase, which is developing the strategy, the goals and the objectives, and then discussed phase 3, which is action planning, where we actually put those objectives into action by developing performance indicators and performance targets and identifying, timelines and people responsible for achieving each objective. And then this led us into the discussion of phase 4 of the strategic management cycle, which is the monitoring and progress reporting and feedback that then is used to inform the next cycle of strategic planning. We concluded by discussing, the strengths and the opportunities that strategic planning offers, some of the pitfalls, some of the do's and the don'ts, and we did a quiz to learn more about that. Do you guys have any questions related to the strategic planning or strategic management process? Okay, one of the products that we looked at a couple of weeks ago was we examined, briefly the strategic plan of the Florida Department of Public Health and the strategic plan of the Illinois Department of Public Health. And you will recall that both of those strategic plans had as one of their priorities improving the health of the communities that they serve, okay, or improving the health of the populations that they served. And one of the key ways that public health agencies go about seeking to improve the health of the communities that they serve is through program planning, management, and evaluation. Okay, so the execution of most, if not all, public health strategic plans is going to involve some aspect of program planning, management, and evaluation. So again, what we're going to discuss this week and next week is specifically how do we go about planning, managing, and evaluating a public health intervention. And we're going to define an intervention broadly to include both public health policies as well as public health programs. And we will make those distinctions clearer as we discuss our topic today. At any point, again, as I mentioned last time, please feel free to stop me and ask questions. So what are our objectives for this week and next? We really have one big objective, which is learning and applying the principles of program planning, development, budgeting, management, and evaluation. Okay? So the different aspects of the program design process. Specifically, we're going to examine the ecological framework that informs program development, and then we're going to discuss each of the steps and the procedures involved in program planning, management, and evaluation. So before we really get into the different phases of program planning, I believe it's very important that we revisit the ecological framework. And I say revisit because I believe that Dr. Beatty, during your very first class, discussed the ecological model of health status and health outcomes and how the different determinants of health contribute to health outcomes. But this is such a foundational concept in the field of public health and in the area of program planning that really we would be remiss to begin our discussion of program planning without, again, revisiting the ecological framework and discussing how it should always inform our program planning efforts, including your team efforts as you develop phase 2 of your project, which is your program plan. Okay, so keep this in the back of your mind and in front of you on your work table as you work on that phase 2 of your project. So this is one way of depicting the different determinants of health. And again, I'm pretty sure that you have seen this slide before, okay, during week 1. Is that accurate?
Yes.
Okay. And again, at that time, I'm sure Dr. Beatty discussed the 5 different categories of determinants of health. So the different groups of factors that affect health status and health outcomes. And those 5 determinants of health are highlighted on this slide. They are the social determinants of health, the physical determinants of health, the behavioral determinants of health, the genetic determinants of health, and the access to healthcare determinants of health. So 5 key determinants of health. Okay, I know you know them because they were on your midterm exam. So again, just as a refresher, the social environment or the social determinants of health, this refers to the socio-economic or socio-demographic environment in which individuals live. So think about the educational levels in your community, the high school graduation rates. That's a key indicator of the social environment in any given community. Think about the poverty rates in a given community. That's a major determinant of health status and health outcomes. Employment rates in a given community. The racial ethnic distribution within that community. So educational levels, again, employment, poverty, those are key indicators of the social environment in which we live. Another key determinant of health is the physical environment in which we live. So here we look at the quality of the air that we breathe, the quality of the water that we drink, that we take for granted, is going to be clean and free of germs. The quality of the soil that our kids play in, the quality of the homes, our houses that we live in. I lived in inner city Baltimore for many years, and in inner city Baltimore, lead in the paint of homes was a major problem that threatened, the health of kids. Okay? Lead-based paint. So the physical environment is very important. A third determinant of health is our biology, our genetic makeup, okay, that can predispose us to certain conditions or diseases. Okay. Predispose us meaning makes us more vulnerable or at higher risk of acquiring certain conditions or diseases. I was at a conference last week, and one of the keynote speeches was about addiction, alcohol addiction and drug addiction, and the growing body of evidence linking susceptibility to addiction to our genetic makeup. Okay. So there's very strong evidence now that addiction is not, simply a behavior, that there are individuals who are predisposed at higher risk of utilizing alcohol and drugs and becoming addicted to them, just like other diseases. We know that the genes play a big role in people's susceptibility to certain cancers, for example, and other conditions. A fourth major determinant of health is individual behavior. So this includes our lifestyle factors. Okay. Our diet, our exercise habits, and other behaviors that can, again, affect our health outcomes. The fifth determinant of health is access to quality health care. And this was covered, by Dr. Hale earlier this semester. The fact that there are different dimensions of access to care, including affordability, accessibility, acceptability, and how those factors, again, affect our healthcare utilization and our healthcare outcomes. So you know all of this. This is not new for you. And this is really not the point of this slide. The point of this slide is to highlight the interactions among those determinants of health. That is why you have those arrows going in all directions. Yeah. So the key point of this slide is that the different determinants of health interact with one another and influence one another, and that this interaction is what ultimately determines the health status of individuals and populations. So the determinants of health are not independent of one another. Okay? And by now you should know that the overarching determinant of health is what? The social environment, right? So the overarching determinant of health that affects all other determinants is the social environment. Okay? Why is that? Very simple example. Our income level, for example, as a family, as an individuals, determines where we live, determines what we eat, determines our access to healthcare, and so on and so forth. Okay? Poor individuals, poor communities, are more likely, to live in risky physical environment or in homes that don't have access, for example, to all of the utilities that they need. They're more likely to engage in risky behaviors. They're less likely to have access to quality health care. Okay? So we can educate those disadvantaged populations about their behaviors all day long. But unless we are able to impact the environments in which they live, our education will have a very, very limited effect on their health outcomes. One of our doctoral students here in the college, she will be defending her dissertation on October 27th. And I happen to know that because I'm on her dissertation committee. But she is doing her dissertation about food deserts in the state of Tennessee. Have you guys heard the term food deserts? Okay. So what's a food desert? What's a food desert?
You don't have access to shops that sell quality food, like vegetables, fresh vegetables and all that.
Okay. So there are areas, geographic areas exactly, where perhaps the only stores available are convenience stores or small, supermarkets that have a limited, selection of food products, typically not, fresh fruits and vegetables. Okay. And there are many, many zip codes throughout the state of Tennessee, throughout our country, and throughout the world that are food deserts, where fresh fruits, fresh vegetables are simply not available in those communities. So we can go into those communities and we can educate those people all day long about the importance of eating 5 servings of the fruits and vegetables every day, and about how to prepare healthy meals, and why eating healthy is good for their heart and weight and all of that. But if they don't have access to healthy food in their environment, or if they don't have the resources to pay for healthy foods, which sometimes is more expensive than processed foods, our education will achieve nothing. In fact, it could make them more anxious and less happy about their situation than result in a positive impact. So this is not to take away from the importance of health education programs. Health education programs are extremely important, but they are certainly much more effective when they are implemented as one component of a larger intervention that also seeks to influence the other determinants of health, including policies, the social environment, or the physical environment in which people live. So, for example, if we educate those disadvantaged communities about healthy eating, and at the same time teach them how to grow their own gardens in their backyards, or subsidize healthy food options in their communities, or support farmers' markets to open up in their communities, then our education initiative has a much higher chance to succeed. Because now not only are we educating them, but we're also providing them with the tools and the resources that they need to have in their environment for them to be able to engage in those desirable behaviors that we're teaching them about. Similarly, if we educate people about the importance of exercising, but there are no sidewalks in their communities, and they don't have access to gym facilities in their communities, or safe parks where their kids can play without the parents worrying about their kids being kidnapped or shot, then our education about exercising is not going to be helpful at all. And I'm not making this stuff up, guys, but I will never forget the one time I was doing research in the Mississippi Delta region. Some of you have heard about the Mississippi Delta. It's one of the poorest areas of our country. And I was conducting focus groups with African American women at the community center in their town about breast cancer screening, mammography screening. So I was sitting with a group of women discussing breast cancer screening. And we start hearing shots outside the community center. And I'm like, what's going on? And the ladies are like, oh, don't worry about it. This happens every day. Keep going. I'm like, are you serious? They're like, yeah, everything is fine. And then she screams at her son just to make sure he's inside. And I'm thinking to myself, I must be stupid, trying to talk to those women about breast cancer screening when they're having to deal with shootings in their backyards every day. So what's their priority? Is their priority making sure that their kids are safe and have food on their table for dinner? Or is their priority going and getting a mammogram to prevent a cancer that may or may not happen down the road? Because this stupid lady from the university thinks different. Right? So all of those stories, again, which are real stories, are just to tell you that, again, while health education and encouraging behavior change is very important, for it to be effective, it has to be implemented within the broader environments in which people live and in conjunction with other initiatives and policies that seek to impact that broader environment in which people live. So practically, what this means, when you are working on phase 2 of your project, when you are designing an intervention to address the priority health problem that you will be identifying in phase 1, if all you do is propose a health education program, trust me, Dr. Beatty, I'm going to say that in my southern learned accent, Dr. Beatty ain't going to like that. And Ms. Weber ain't going to like that either. And I'm going to hear about it downstairs, and I'm not going to like that either. So when you're designing, I'm serious, when you're designing your intervention to address your problem, it's certainly okay to include a health education component, again, seeking to influence behaviors. But make sure if your problem has socioeconomic roots or underlying factors, which chances are all public health problems have social roots, that you're doing something, that you're proposing some initiative, some policy, some intervention to, again, try to address the broader environment in order for your education efforts to be successful. Any questions about this? I know I've rattled for a while. Any questions about this? You guys, you get the point?
Yes.
Are you with me?
Yes.
Okay. So this here is another way of presenting what I just talked about. And actually this slide makes it even clearer that while individual behaviors directly impact health, those individual behaviors are embedded within our social and family networks, which in turn are embedded or determined by our living and working conditions, and those ultimately are determined by the broad socioeconomic environments in which we live. This is the model that was adopted by the Healthy People 2020 initiative. And again, at the beginning of the semester, Dr. Beatty discussed, Healthy People 2020. But this is the conceptual model that was used to design the Healthy People 2020 objectives. Again, the idea is interventions, whether they are policies or programs or informational interventions, i.e. educational programs, those interventions, for them to be most successful, they have to cut across the multiple determinants of health. That's why this arrow goes across those circles. Okay? Only then, only when our interventions are seeking to improve our socioeconomic environment, our living and working conditions, only then will they be successful in changing the outcomes highlighted on this side of the slide. Okay? Any questions about this? Okay. So now that we, again, revisited the ecological model of health, and hopefully we are all on the same page in terms of what the determinants of health are and how they interact, we can begin to describe the different steps and procedures for program planning and evaluation. All program planning and evaluation should begin at the community level. Again, this is not news for you. Okay? This is really the material that was discussed 3 weeks ago when Dr. Beatty covered partnerships and coalition building. Okay? So as public health leaders begin to think about developing public health programs or policies, one of the first things that they need to do is to put together the team, the partners from the community, the coalition, the network, whatever it's called, but really the organizations and the individuals that will work together to assess what the community needs are and to determine what the priority health problems are. And again, this is exactly what you will be doing for phase 1 of your project. Okay. You will be proposing the development of a community partnership. You will identify the key organizations and individuals who should be involved. You will develop a mission and vision statement for your partnership and a set of core values and operating rules. Okay? So you're going to be putting, this again, you're going to be applying this during your project. This community partnership, then this coalition, becomes, the entity that engages in the program design. So program design or program management consists of 3 phases: planning, implementation, and evaluation. Again, although those are listed here in the form of bullets, it is really a cycle that we are talking about. So what's that program management cycle look like? Okay. So you have at this point, you have your coalition up and running, and they're ready to begin, designing an intervention to address, again, whatever priority health problem has been identified. And I know that each team has identified a different public health problem that they will be examining. So for a program design process to be efficient and to be effective, it needs to follow those different steps in the order presented here. We start by developing a statement of the problem. We then review the scientific literature related to that problem. The review of the scientific literature will inform the analysis of the problem for its risk factors. Once we've analyzed the problem for its risk factors, we can develop the program or policy options. We can then develop the work plan, implement our intervention, and then evaluate our work. And based on the evaluation findings, typically one of three things happen. We either find that our intervention worked perfectly well, and so we then disseminate it widely, or the evaluation finds that some aspects of the intervention worked well and some aspects did not. In that case, we will retool our intervention, continue with the aspects that work, and modify the aspects that don't work, and then implement the new version of the initiative. Or the third possible outcome of the evaluation is we may find that the initiative is not working at all, it's not successful, in which case, and although this would be a difficult decision to make, but we should decide to discontinue that intervention. Of those three evaluation outcomes, disseminate widely, or discontinue, or retool, which one do you think is the most common?
Retool.
Retool is the most common. Okay, so typically, again, after we implement an initiative and we evaluate it, typically we find that certain aspects are working well, other aspects can benefit from improvement, so we will retool it before we disseminate it on a wider scale. So, starting now, the rest of our class time today and our time next week, what we will be doing is we are going to be discussing and working on each of those phases of the program management cycle. Okay? Learning what it is, working with some examples. Okay? So by the end of next week, we should have a solid understanding of this process, and hopefully then you can apply it for phase 2 of your project. Any question about this before we start delving into each phase? Okay, so the first, again, phase is developing the problem statement and the outcome objective. Again, at this point, your coalition is up and running. You have identified your priority health problem. that you want to target in your community. This can be anything from neonatal mortality to, the cancer death rates, teen pregnancy, high obesity rates, high opioid use rates, etc., etc. So one of the first things, again, that we're going to do is develop our problem statement. Let's be clear, what do we mean by problem? Okay. A problem is an undesirable condition of people expressed in health outcome terms that is likely to exist in the future unless additional interventions are implemented. Okay? So not everything is a problem necessarily, right? And this statement here is important, that is likely to exist unless additional interventions are implemented. Okay? So let's say that infant mortality rates in our community have been steadily declining and are projected to continue to decline because of ongoing initiatives in that area. Then we may not want to identify infant mortality as a problem for our new work. Okay? We need to be focusing on problems that, again, are likely to exist unless new interventions are implemented. Because resources are limited. So if resources are already being allocated to address one issue or one concern in the community, there's no need to duplicate or to do redundant work. Okay? We really need to identify what are the pressing needs that are presenting with high mortality, morbidity, disability, high incidence, high prevalence, and again, where something new has to happen to affect change. So we express a problem typically in terms of one or more of those epidemiological measures that you are learning about in your epidemiology course. So the problem statement. What is a problem statement? A problem statement is a concise and accurate description of the problem that you are seeking to address. Again, for phase 2 of your project, this will be, the first task that you will have to complete is developing a problem statement. And the problem statement is typically a couple of pages. We're not talking here about a textbook. It's typically a couple of pages that include those bullets highlighted on this slide. You want to define your problem, its nature and etiology. You want to describe the magnitude of the problem in terms of its incidence, prevalence, and seriousness. Again, so this is the epidemiological description of the problem. You want to identify the populations that are at high risk for developing or contracting this health issue. So, for example, breast cancer. Yes, both men and women can get breast cancer, but it is primarily a disease of the female population. And while women of all ages can get breast cancer, really women 40 years of age and older are at a higher risk of contracting the disease. So it makes sense if you're working, in the area of breast cancer to identify women 40 years of age and older as your priority population for that effort. Okay? If your problem is high suicide rates in your community, okay, it may make sense to identify college students as your priority population. because we know college students are at a particularly high risk of suicide. Okay? So again, the nature of your problem, its etiology and its magnitude help identify the populations at risk. You want to look at past and future trends in the problem. So, is the prevalence of the problem increasing, decreasing, or stable over time? Are mortality rates associated with the problem increasing, decreasing, or stable over time? Because again, those problems where you have a negative trend, meaning the incidence rates or the prevalence rates or the mortality rates are getting worse, those are going to be your priority problems. You also want to look at past and future trends in the major determinants or risk factors for the problem and where and when they occur. So all of this comes, from your literature. Okay, the problem statement is not something that you guess, okay, or that you draft, based on your knowledge of the world necessarily. It really should be based, on the science and on the literature. After you develop your problem statement, you are prepared then to write your outcome objective. The outcome objective is the level to which your health problem should be reduced and or maintained within a specified time period. Okay? So if you're addressing breast cancer mortality, okay, your outcome objectives should address the future desired level of breast cancer mortality rates within a defined number of years. If you're addressing obesity rates among children in your community, your desired outcome objective should address, again, the future desired reduction in obesity rates among children in your community. Objectives, as we discussed a couple of weeks ago, should be SMART, okay? A couple of weeks ago, we talked briefly about SMART objectives, and I promised you that today we will delve deeper into them, and we will learn what it really means to write a SMART objective. So SMART refers to specific, measurable, attainable, results-oriented, and timely. A SMART objective is a specific objective, meaning it's concrete, starts with an action verb, such as increase or decrease, and identifies the priority population, which is the population at high risk that you're targeting. A SMART objective is measurable, okay? So it specifies the magnitude of change that you are expecting to see after you implement the program relative to baseline. A SMART objective is attainable. That means that it's feasible and achievable. It should be ambitious, but at the same time, it should be realistic. A SMART objective is results focused. It's not focused on activities, it's focused on outcomes, and it's timely, meaning it identifies the time frame and target date. So now what we're going to do, and keep those definitions of SMART in mind, we're going to look at a number of hypothetical objectives. We're going to do a short exercise. And you're going to, with your neighbor, you're going to examine each of those hypothetical objectives, and you're going to answer 2 questions about each one of them. The first question is, does this objective meet the definition of a SMART objective? Is it SMART? If the answer is yes, you leave it alone. If the answer is no, you rewrite it to make it SMART. Okay? So you identify what's missing, what needs to be improved, and you incorporate those missing elements into that objective. Okay? So we're gonna do the first one together as an example, and then you're gonna do numbers 2, 3, 4, and 5. Okay? So let's take a look at the first one. To increase the measles immunization rate among 2 to 3-year-old children from 70% to 90% by 2018. Okay? So SMART, we start. The S.
Specific.
It's specific to what?
Measles.
To the measles immunization rate. Okay. Does it identify the priority population?
Yes.
What's the priority population
2 to
here?
3 years old.
2 to 3-year-old children. Is it action oriented?
Yes. Yes.
What's the action verb?
Increase.
Increase. Does it present the magnitude of change, the desired magnitude of change?
Yes. From 70 to 90.
From 70% to 90%. Does it present the time frame
Yep.
by which
By-
this change should be achieved?
It's time bound. 2018.
By 2018. But since when?
Right now.
Do we know?
No.
So it presents the baseline percentage, the baseline immunization rate, but it does not tell us 70% in what year,
Yeah.
Okay.
right? So it's missing the baseline year. Okay? So again, it doesn't specify this 20 percentage point increase in the immunization rate is to be achieved within what time period? 3 years, 4 years, 5 years? We don't know. It says by 2018, but it doesn't say since when. Okay? Place. Does it specify the place? Okay. So we don't know where. Children where? In Johnson City, in Washington County, in the state of Tennessee, in Nigeria. Right? Okay? So this is a good objective, but for it really to be a SMART objective, it should be something like to increase the measles immunization rate among 2 to 3-year-old children in the state of Tennessee from 70% in 2015 to 90% by 2018. Okay? Now it's a SMART objective. Okay? Now it contains all of those key elements. Yes.
Sorry, I'm gonna pick on a buy. So whenever you say buy so time, it means you can even stop before that. So will it be smart enough to say we're gonna stop at so year rather than saying buy?
So by in this context means by the end of 2018 that you're expecting or you're desiring to achieve this change by the end of 2018. You could achieve it earlier, but your target, your desired target is no later than the end of 2018. So again, what's interesting to me is actually this is not even a complete sentence, folks. Grammatically, this is not a complete sentence yet, yet you can write an objective that's not even a complete sentence that packs all of those smart components into just, one or two lines. Okay? So it's an art and it's science, but it's very important because unless your objectives are clear and smart, there's really no way to evaluate whether you've achieved them or not. Okay? So I'm going to stop there and give you now some time again to work on the other objectives.
It doesn't matter. Look at
Okay, so the second objective, to decrease the prevalence of smoking cigarettes in the state of Tennessee to 10% by 2016, baseline 35% in 2010. What did you think about this one, guys?
There is a specific population missing.
The specific population is missing. Okay, so we're not sure if this is to decrease the prevalence of smoking among all Tennesseans or among certain subgroups. Okay, any other concerns with this one?
Is it like the 10% of the whole population is not going to be smoking? What's 10%? Is it 10% among smokers or 10% among the whole population?
No, so the baseline is 35% in 2010. This means that in 2010, 35% of the population reported smoking. Okay, so this is the prevalence. It's not new people who started smoking in 2010. It's the total percentage of smokers in 2010. So they're seeking to reduce that from 35% to down to 10% in 2016. What do you think about this proposed magnitude of change?
Too much. It's not realistic. You know it's not.
It's overly ambitious, may not be attainable, may not be realistic. I mean, that's a pretty huge decline that they're expecting within
6 years.
5 to 6 years. And given what we know about changing smoking behavior and the fact that it is addictive and all, this is likely, again, based on the literature, this is likely an overly ambitious magnitude of change. Okay? Number 3, by 2018, the proportion of Washington County residents ages 40 to 60 years who have been screened for hypertension would be 90%.
So, how many were screened before?
The active word is
Yes.
It's missing a baseline and a specific action verb
It's missing the baseline
data.
percentage, so we don't know what proportion of this population was screened at baseline. Okay, what is it also missing? The time frame, so 90% by when? We don't know, so we don't have a baseline here.
Isn't that
And
that's
the- I'm sorry, 2018, right. So we have the target here, we just don't have the baseline percentage or the baseline year. Okay. I'm sorry. And because we don't have the baseline percentage and the baseline year, can we really assess if this is a realistic,
No.
achievable objective or not? We can't really make that assessment because we don't know where we're starting, right? Okay. If we're at 80% now, we might be able to increase it to 90%. But if we're at 30% now, right, then that's a different story. Any other concerns about this objective? You said it's missing an action verb. Someone said that, right? Actually, the action verb is, I totally see your point that it's not stated at the beginning, but it's implied, I guess, in the middle here, which is screen. I mean, that's the action that is to increase the screen. So you can rewrite it to say by 2018, or to increase the proportion of residents who are screened to 90%. You can certainly do that, or it's implied here. Okay, 4 and 5. So let's take a few more minutes and work on 4 and 5. Okay, so number 4. This program seeks to promote exercise among the elderly residents of Sullivan County. What do you guys think?
It's not more objective, it's a goal.
It's bad, it's a goal.
Yeah.
It really looks more like a goal. Remember a couple of weeks ago we talked about goals versus objectives, where goals are broad and not specific.
It's not measurable.
So exactly, it's more like a goal, it's not measurable.
So we don't even know if it's achievable.
It's missing
Everything.
everything that it needs to be smart. So this guy is gonna take a lot of work, right?
Right.
To turn it into a smart objective. Did anyone attempt turning it into a smart objective, or you just gave up on it?
Working amongst.
Can I see like a hand or two who would like to? Okay, Irati wants to try, and then we'll check with you, ladies. Let's please hear our colleague.
The program seeks to increase the activities among exercise activities among elderly people from 10 minutes a day to 1 hour a day, or 3 times a week among the elderly population between 65 and 80 in Sullivan County. From in 2000, I'll people say
It's the more.
2000, from 2000 in 2000. Leave me alone. Okay, from in 2010 to 1 hour a day in 2018.
We're gonna have to separate you, ladies. We're gonna have to put Sylvester
Oh no,
between.
you wouldn't want that.
Okay, so did everyone hear that?
Yes.
Okay, what do you guys think? A minus, B plus? Okay, I think we had another volunteer here.
Yeah.
Thank you, that was good, Irati.
We said something along the lines of like building a sidewalk to promote exercise among the elderly, and you could say like 60 to 80. And then it would start in 2016, and the end goal would be 2018 to increase our activity level to like an hour a day or something.
Okay, thank you, sounds good. Yes, ma'am.
This program seeks to promote exercise among the elderly residents of Sullivan County from 50% of the elderly residents in 2017 to 70% in 2020.
Minutes.
Yeah, doesn't speak to what type of exercise. I think this is what you started to get at, that at least the time,
During the week.
and also with exercise we have to think about intensity, right? Because not all exercise is created equal. Okay, so like I go on a leisurely walk sometimes, for 20 minutes after dinner, and I convince myself that's exercise. And my son is like, who's a basketball player and a soccer player. He's like, "What are you doing, Mom?" Like, "I'm exercising." And he just laughs.
Mike.
Good job.
So, thank you. So number 5, the objective of this program is to increase the proportion of Tennessean children ages 5 to 14 years who always use seat belts in the cars. The current figure is only 70%. What do you guys think?
The only thing is the time.
What's missing?
No magnitude of change.
Yeah.
It's missing the time frame, so there's no baseline here and there's no target here. Okay? And you said it's missing the magnitude of change because we don't know what the current, we know the current figure, but we don't know the desired figure, the desired percentage. Okay? So, who attempted a rewrite? I know someone did.
So you could say increase the proportion from 70% to 90% by assuming that 70% was the baseline in 2017 by 2020.
Okay, so the suggestion that we have is to increase the proportion of Tennessean children 5 to 14 years who always use the seat belt from the current figure of 70% in 2017 to 90% by 2020, if I heard you correctly. Okay. Any thoughts about that?
I just have a question.
Yes.
If it says current figure, do we need to assume that it's this year, or should that be specified as well?
You know, it has to be specified because typically the way data are available, the current figure is actually never the current year. Okay? So 2017 data, for example, if we're lucky, will come out in 2018 or 2019. Okay. Currently in 2017, the most current data that we may be able to put our hands on in 2017 is going to be 2 to 3 years old, you know, at best. So yeah, that's why it's important to specify the year. That's a good question. Yes.
Is it okay to use the word always?
How do we monitor always?
Yes, so is it 100% compliance? Is it 95?
Always, yeah, would imply not occasionally. So regularly, you know, 100%, yeah. And if it's if it's a law, I mean, you should expect 100% compliance if the law is being enforced the way it should be enforced.
Sorry. So if that's the case, then we can just omit always then, since it's implied. So
Would it be
Who
better
use?
to use a word like consistently or something?
Yes. Yes, there are better ways of stating that. I agree.
So when you guys are writing your SMART objectives, a lot of this language will have to do with the data that are collected. So if it's collected where the state of Tennessee records it as always used, then that would be the correct way. But if it's just some other way that they collect it, that will be the most appropriate language, if that makes sense. So we don't know if this was the author's language or if this is how the data are presented.
Collected, yeah. Because a lot of times, exactly as Dr. Beatty mentioned, a lot of times this kind of data comes from ongoing surveillance systems. So it's secondary data. So it depends on either how the question is asked on the survey or how the law enforcement agency reports it or how the State Department of Health or the CDC captures that measured in their surveillance systems. So, how comfortable do we feel writing SMART objectives at this point? Okay, because again, this is important, and you will be expected to again write objectives for your project. So why don't we take a short break at this point, now that we've completed the develop problem statement phase, and we will return at 2:30 and to discuss the lit review. Thank you. Okay, so at this point in our program management cycle, we have developed our problem statement and we have developed our desired outcome objective, reflecting the future desired level of our health problem. So now we need to further investigate the literature. So again, earlier I mentioned that your problem statement should be informed by the literature, by the scientific evidence, but you really need to be revisiting the scientific literature at multiple points throughout your program management cycle. And after you develop your problem statement is a good time to take a deep dive into the scientific literature in order to achieve two important outcomes. First, you want to identify the risk factors that are associated with your health problem. And second, you want to identify state-of-the-art interventions that have been proven effective in other settings or with other populations that you might be able to use or adapt in your population. Okay? So again, two important purposes of the scientific literature here, and we will talk about each one of them, starting with identifying the risk factors that contribute to your health problem. So what you see here is what we call the health problem analysis. And this is where you begin to, again, identify what are those risk factors that contribute to the health problem. Because obviously, if you want to change the level of the health problem in your community, in your priority population, you're going to have to address multiple risk factors in order to achieve a change in the level of the health problem. So risk factors exist at multiple levels. There are risk factors that live very close to the health problem, and there are risk factors that live a bit farther away from the health problem. And we call them different things depending on their proximity to the health problem. So the risk factors that directly impact the level of the health problem, we call those the determinants. So your determinants are your risk factors that directly affect the level of the health problem in your priority population, such that a change in the level of the determinant will directly lead to a change in the level of the health problem in your community. The determinants themselves are influenced by other risk factors. And the risk factors that affect the determinants are called the direct contributing factors. So the direct contributing factors are your risk factors that directly impact the level of the determinants, such that a change in the level of the direct contributing factors will lead to a change in the level of the determinants, leading to a change in the level of the health problem. Okay? And finally, your risk factors that affect your direct contributing factors, we're gonna call those your indirect contributing factors. So those are gonna be community-specific factors that influence your direct contributing factors. This all sounds totally crazy and meaningless until we look at an example. Okay? So let's take a look at an example and see how this translates into real life. So in this example, the problem is neonatal mortality in our community. And what is neonatal mortality?
First less than 28 days.
So neonatal mortality is the neonatal mortality rate is the number of infant deaths within the first 28 years of life per
28 days.
Yes.
Okay.
Neonatal mortality is within the first month, pretty much. Infant mortality are deaths within the first year, okay, per 1,000 or per 10,000 live births. Neonatal mortality are deaths within the first 28 days of life per 1,000 or 10,000 live births. Okay, so it's really what happens during the first month of the life of the newborn. Okay, so neonatal mortality, one of the key determinants of neonatal mortality is low birth weight. Okay, we know that infants who are born with a low birth weight are at higher risk of dying within the first 28 days of life. Okay? So in a community or among a certain population, the higher the rate of low birth weight infants, the higher the neonatal mortality. Okay? It's a direct relationship. Low birth weight rates is a determinant, is a risk factor that directly impacts the level of neonatal mortality in the community. Low birth weight itself is affected by multiple risk factors or direct contributing factors, including tobacco use in pregnancy, low maternal weight gain, and inadequate prenatal care. So those are some of the key, again, risk factors that influence the level of low birth weight rates in a community. In other words, the higher the proportion of women who use tobacco while pregnant, the higher the low birth weight rate in that population. Similarly, mothers who do not gain the appropriate weight during pregnancy are more likely to deliver low birth weight infants. And women who do not start prenatal care until late during their pregnancy or who do not have prenatal care at all are also significantly more likely to deliver a baby with a low birth weight. So in this example, tobacco use in pregnancy, low maternal weight gain, and inadequate prenatal care are direct contributing factors. They are direct contributing factors because they directly affect the level of the determinant, which directly affects the level of the health problem. Now notice that determinants and direct contributing factors, both of those risk factors are universal in nature. What that means is in any community, in any country, in any continent around the globe, those relationships hold. wherever you are, in any place, higher rates of low birth weight infants will translate into higher neonatal mortality rates. Wherever you are in the world, higher rates of tobacco use in pregnancy and lower levels of prenatal care will translate into higher low birth weight rates. However, the indirect contributing factors, which are here at the very bottom of this slide, the indirect contributing factors are community specific, meaning they can and typically do vary between one community and the other. So for tobacco use in pregnancy, this risk factor, the level of tobacco use in pregnancy, is affected by the extent to which people have easy access to tobacco in their communities, and whether or not there are education programs or cessation programs targeting pregnant women, okay, to decrease their use of tobacco during pregnancy. So in communities where there is easy access to tobacco, you can buy tobacco products anywhere pretty much, or get them from friends or family easily. And in communities where there are no or very few education or cessation programs, you're going to see higher rates of tobacco use in pregnancy. Whereas in communities where access to tobacco is limited and where there are available and effective education or cessation programs, you're going to see lower tobacco use in pregnancy. Okay? So again, access to tobacco in this example and education-cessation programs are community-specific risk factors that impact the level of tobacco use. Similarly, the access to healthy foods in a community and the availability of WIC programs, those are government-subsidized women, infants, and children programs, will affect maternal weight gain during pregnancy. Similarly, access to prenatal care services and transportation will affect whether or not pregnant women receive adequate prenatal care. Okay? So again, all of those factors at the very bottom of the slide are your indirect contributing factors that are community specific, that affect the level of the direct contributing factors, which in turn affect the levels of the determinants, ultimately affecting the level of the health problem. Okay? So let me ask you this question now. If you are designing a program to decrease neonatal mortality in your community, at which level will you intervene? At the community level. You will intervene with the indirect contributing factors. Okay? So I do this every year in class to try to illustrate, this point, and Dr. Beatty is sick and tired of seeing me do this. But you can. So let's say this is your problem here. Okay? I'm your problem. I'm neonatal mortality. Okay? And I'm here. You analyze your problem for its risk factors backwards. Okay? So you take a step back and you identify the determinants that affect the level of neonatal mortality. You take another step back and you identify the direct contributing factors that affect the levels of the determinants. You take a third step back and you identify the indirect community-specific factors that affect the level of the direct contributing factors. So you analyze the problem backwards, but then when you're ready to design your program, okay, you're gonna move forward. So you're gonna intervene, as you mentioned, at the community level with one or more of those indirect contributing factors. So you're going, for example, to limit access to tobacco and make sure that pregnant women have access to tobacco cessation programs. This is what you're gonna do. Those are gonna be your activities, okay? And if you've done your analysis correctly, everything should fall into place after that, okay? Okay, so if you've done your analysis correctly, you limit access to tobacco, you increase cessation programs, you increase access to healthy foods, then you should see lower tobacco use in pregnancy, which should translate into fewer babies born with low birth weight, which should translate into lower neonatal mortality rates. Okay? So that's the whole, concept here. Any questions about this? Yes.
So in thinking about the objective being measurable, how does one project how big of an impact they could have at the community level? Like, for example, how do you know you can lower neonatal mortality from like 35% to 25%?
Yeah, so this is an excellent question. So what we're gonna talk about next is actually the different levels of objectives that you have to develop. Okay, so we talked earlier about your outcome objective, right? Which in this example would address the level of neonatal mortality. But once you've analyzed your problem for its risk factors and you've identified your intervention strategy, so are you going to intervene with tobacco use in pregnancy, or are you going to intervene with low maternal weight gain, or are you going to intervene with inadequate prenatal care, or with all three, or with 2 out of the 3? Okay? Then you have to develop your process objectives and your impact objectives. Okay? Your process objectives will address the future levels of your contributing factors, and your impact objectives will address the future levels of your determinants. We'll talk about that in a minute. And then you will revisit your desired outcome objective that you developed earlier to see if achievement of your process and impact objectives will actually lead to the achievement of the outcome objective as you had stated it, or if it needs to be revised. Okay? So we'll talk about that in a minute. That's an excellent question. Let's just make sure again that we're comfortable with this concept, and let's try to do another example here together. Okay? And you're gonna have to help me. You're gonna have to think fast and loud. Okay? So in this example, we're gonna our problem is gonna be breast cancer mortality, and I'm using that just because it's an area that I've researched for many years, so I'm comfortable with it. So breast cancer mortality, deaths from breast cancer. What would you say? What are the key determinants of breast cancer mortality?
Genes. The genes. That's the biology co-factors. Genetics.
Right. So genetic factors are very important, and there are genetic mutations that predispose women to breast cancer, to developing breast cancer. From a public health intervention standpoint, would you say we will focus our efforts there, or focus our efforts on more modifiable behaviors? What do you think? Modifiable behaviors? Okay. Yes.
Late detection.
Late detection. And how do we detect breast cancer typically? What's the gold standard? Mammograms. So screening mammography rates, right? Screening rates. The higher the screening rates in a population, the earlier the cancer is detected. And we know when cancer is detected early, treatments are much more effective, right? And survival rates are higher, which translates into lower mortality. Okay? What's another key determinant of breast cancer mortality? Yes.
Maybe the socioeconomic factors, because lack of education, and that leads to not examining, self-examining the breast and not knowing about it.
So lack of education, you said, wonderful. So you said lack of education affects the examination rates, if I heard you correctly, right? So based on what you just said, where would lack of education go? At which level? And I'm going to repeat what you said. Lack of education affects examination rates. It should go here, right? So we're going to put then the education levels of the community, their awareness, their knowledge awareness about screening, knowledge and attitudes. Now you cannot see it, so I'm going to make it larger. Okay, here we go, that's better. So awareness of the importance of screening, attitudes towards screening do determine screening rates. Again, women who are more aware, who are better educated, who have more positive attitudes about screening are more likely to get screened. Let's go back to the determinants.
How about lifestyle?
So a woman screens. Let's follow that thought. What should happen after screening?
Oh, regular doctor.
She screens, cancer is detected. What should happen next?
Treatment.
Early treatment. Okay. So really, treatment effectiveness, prompt and effective treatment. Again, if a woman who screens positive was diagnosed, the earlier she starts treatment, and if there are effective treatments out there, the lower the chances of her dying from the disease. So, as public health professionals designing a program to reduce breast cancer mortality, then our intervention strategy can target increasing screening rates or increasing, treatment rates, or both, depending on the resources that we have available to us. Okay? Let's focus for a second on screening, since we started with already with addressing the factors that contribute to screening. So we said knowledge, awareness, attitudes about screening affect screening rates. What else affects screening rates?
Access to screening facilities or tests. Geography.
Access, right? To screening facilities or tests. What also affects screening rates? Cost. Hold on that idea for 1 second. Yes.
I think poverty and unemployment might do that.
Poverty and
if someone doesn't have money, they will not afford it to go for screening.
Okay, so I think we're thinking along the same lines: cost and poverty as determinants of what? Of access, right? So access, again, remember, access has multiple dimensions. are the services available in the community? Are there mammography facilities in the community? And are there low cost, free or low cost mammograms in the community, right? What affects knowledge levels, women's awareness, attitudes?
Education, like education programs.
If there are education programs or campaigns, right? Again, to try to raise community awareness about this condition. Like October, for example, there's lots of educational awareness activities all around us, right? The pink ribbon everywhere. That's part of raising awareness, educating the community. Okay. Any other thoughts? Can a woman go get a mammogram by herself?
No.
What does she need to get a mammogram? A doctor's referral, right? So, in the literature, actually, a doctor's recommendation or a doctor's referral has been found to be a key predictor of screening rates. So if the doctor is not counseling her about screening, recommending it, referring her, then screening rates will be lower. And what affects whether or not doctors counsel their patients and make that referral?
If they have insurance or not?
If the patient has insurance or not, or?
Access to health clinics.
I'm sorry?
Access to health clinics.
Access to health clinics?
Knowledge.
The doctor's knowledge?
The patient has to ask.
What if the patient doesn't ask? Is it the doctor's responsibility to counsel? Yes.
Well, the level of risk factor is not the things the patient has for that.
I'm sorry, say that again, please.
Age, for instance, doctors might be more likely to tell you to do a screening or not, or other risk factors they feel you might have towards breast cancer.
So their assessment of the level of risk of the patient? Okay. So knowledge, training, etc. Okay. So again, this is rough, but it's designed, to just give you an idea of how things work. Yes.
Sorry, the quiz we did, I don't know, based on the quiz, should that be education or promotion?
Based on?
Health promotion or health education? The one by the left, yeah.
Yeah.
Based on the quiz, should that be health promotion or health education?
Based on the quiz, should this be health education or health promotion? If we're just trying to change the knowledge level, the level of awareness, that's a health education program. A health promotion program tries to change the broader socioeconomic factors. So a program that seeks to increase mammography facilities in the community or provide them at low cost or train providers, that would be considered a health promotion program. Yes, sir.
I don't seem to understand why you don't want to talk about the non-modifiable risk factors such as age, gender, race in this setting.
Yeah, that's an excellent question. So those are very important, risk factors. But as I mentioned, they are not modifiable, which means that they're not amenable to intervention. So we cannot really change a woman's age. We cannot change her race. Am I getting your question? So we're trying to target here risk factors that are amenable to change. Yeah.
Alright, so if, for example now, if we are working on a program and we said the program has to be specific, it has to have a target. Okay. Why do we, if we discover that a particular area, by the time they are 50, they come down with breast cancer, but by the time they are 20, we want to be able to pick them, but they are falling under category of non-modifiable, like young girls who would not. But we know by the time they are 50, how do we intervene at 20 so that by the time they are 50, would this program still work for people who, do you get what I'm trying to?
Yeah. So this program, yeah, thank you. This program is actually this program would specifically target women who are 40 years of age or older. But you could certainly have a different kind of program that seeks to change lifestyle or increase genetic testing that targets women who are at increased risk at a younger age. This is for the general population, women who are 40 plus. So yeah, that's an excellent point. That for populations that are at higher risk, you would have to do something different. Yes, I'm sorry.
So those non-amenable risk factors are very important though. In public health, we use those to identify the target population. So we know that African American women are diagnosed at a higher level or a more advanced level and they die more. We don't just say, well, we can't do anything. Those are the women that with our limited resources we focus our energy on, because making changes in those can make an impact on the population, but we also have identified a group that has a disparity. So we use those non-amenable factors to identify the groups that are at most risk to use our funds for.
So when I did, for example, this kind of work in the state of Mississippi, our priority population was low-income African American women. So we tried to increase the screening rates specifically in that population, because again, as Dr. Beatty mentioned, they experienced a disparity. They experienced higher breast cancer mortality rates than, for example, white women in the state or women with higher incomes. So yeah, I'm sorry if I wasn't clear. It's not that we disregard the factors that are not amenable to intervention, which we focus on them to identify the populations at risk. But when we're analyzing for the risk factors, we focus on those that are amenable to change. Yes.
So using your case study as an example, the one you had at Mississippi.
Mm-hmm.
So we know that the income, it's actually a problem in that regard.
Mm-hmm.
So and you told us to target the root, and that happens to be the root of the problem. If they are low income earners, they are more likely to end up in this group. So how do you deal with that? How do you make sure that you bring them to the middle income level, for example, so that it trickles down to the main problem? Because that seems to be the root.
Right. So in this case, obviously they're doing programs that are 3 years, for 5 years. I mean, that's the funding that we have available for that period of time. Ultimately, ideally, we do want to increase job opportunities and the income levels of those populations. Realistically, though, within the funding that we have available and the duration that we have available, perhaps the best that we can do is to address their, low income issue, is make sure that they have access to free or low cost mammograms in their community. Because again, in that case, I think we had funding for 3 years, for example. We had a grant from the Susan G. Komen Foundation to do this work over a 3-year period. And we needed to demonstrate an increase in screening rates among low-income African American population within that time frame. So realistically, again, trying to change their job profile,
Yeah,
for
that's my
example.
point, because once the funding ends, then it goes back to the cycle again, and it's like, I don't want to say it's going to be in vain after like 3 years, no more funding for free or low cost, like what we experience about the ACA now.
Yeah.
So
So those are very important points, which is how do you maintain, the sustainability of the initiative after the intervention ends. And actually today, increasingly, funding agencies require you to include a plan for sustaining the initiative after the funding ends. And one of the projects that we're working on now, Dr. Beatty and I, which is also a women's health project, but in a different area. We are specifically going to be measuring policy changes and other factors that will lead to sustaining the initiative. So it's an important point. Are there more questions in the back? Yes.
Well, I'm looking at our plan and I'm asking myself, where does self-breast examination fall within this? Because if you're talking about free and low cost access to mammograms, which is going to end within 3 years, then what else can we do to help these people, but for them to examine themselves? So where can that fall in this?
So all of those programs that when we're designing programs, we have to follow what are the current guidelines, okay, the clinical guidelines. The clinical guidelines have changed, and breast self-exam as a population-wide screening strategy for breast cancer is no longer recommended.
What?
There's a whole body of literature about that, and I can talk with you separately about that. But several years ago, yes, the U.S. Preventive Services Task Force and other organizations have, changed their guidelines to where breast self-exams as a general population-wide prevention strategy is no longer recommended.
So why are they still pushing that agenda?
Where? Who's pushing that agenda?
Well, back home, we are seeing October, I'm still receiving flyers that is encouraging self-breast examination.
Where is back home?
Ghana.
Okay, so every population is different. Okay.
Obviously.
And the clinical guidelines, do reflect that. So the sociodemographics, the risk factors in Ghana may be very different than, let's say, in the US or in the Western world, where there's more access to mammography, and there's so it's not. Again, we can't compare really.
Maybe a funding issue though, that many women are kind of requesting for this mammographic, services more than they actually need. So could that be the major reason why they are pushing for why they are not encouraging for everyone to be doing it at home? Perhaps.
basically the reason the recommendation changed, in the US was that the Preventive Services Task Force found no clear evidence that breast self-exams consistently reduced breast cancer mortality in the average population. Okay, so let's do one more example quickly, because again, this is important, and you are gonna have to do it for your projects. So we're gonna, our next example will be again another women's health issue and really family health issue and societal health issue that, as I mentioned, Dr. Beatty and I and several in our college are working on, and that's the problem of unintended pregnancy. Okay, so this is mistimed or unwanted pregnancy, particularly a problem among teenagers. So going back, to the question that I had, from the second to back row. So in this case, our priority population based on the risk factors are teens and women of younger age, low-income teens and women of younger age who are at higher risk for unintended pregnancy or teen pregnancy. So what would you say is one of the key determinants of unintended pregnancy in a community? In general, let me tell you something in general. Socioeconomic factors in general are community specific and live down here. Okay? In general, I would advise you against putting them up here as your determinant. We see that a lot in the project. Don't do it. Okay? Sociodemographics are community specific, right? Down below. What determines unintended pregnancy? What determines pregnancy in general?
Contraception.
I'm sorry?
Contraception.
So, so whether or not contraception is used, right? Contraception used during what? Sexual activity, right? Okay. So, what determines whether or not teenagers or people in general use contraception?
Beliefs.
So, again, knowledge, attitudes, beliefs. What I also heard,
Availability.
okay, meaning access to contraception. And what else? Similar to screening. Some contraception is available over the counter, some needs a prescription, right? Yes, ma'am.
Yeah, some contraceptives are not effective, like they're not quality products, so when people use them, they do get pregnant, but it's found in
Okay, that's a
developing
great
countries, mostly not here. So.
point. So effective contraception use, that's an excellent point. Thank you. So knowledge, attitudes, beliefs, access, and then providers The provider, right? Knowledge, attitudes, beliefs are gonna be determined by culture, education. Very good. Access is gonna be determined by
Availability, cost.
availability and cost. And providers' use or
Politics, insurance,
politics.
the policies that surround contraceptives, insurance, and
training
of the doctors, whether they
Okay. So you were getting better at this, right? First time it took us what? Forever. Now it's taking us forever -1. But you get the idea, right? Okay. So we intervene at the community level. We really need to make contraceptives more available at a lower cost, educate women about the effective use of contraceptions in order to increase their knowledge, attitudes, and their access, which should lead to more effective and consistent use of contraception, which should lead to lower rates of unintended pregnancy. Yes?
My question is, when you consider the previous one we did and this particular one, I observed we focused on determinant on my left side, and I don't know if what we've mentioned will affect this on the right, or do we have to think about other things that would affect this determinant?
Excellent. So, developing your intervention strategy. How do you develop your intervention strategy? How do you determine what your points of intervention should be? Okay, this is what you're asking, basically. What determinants should we intervene with? How do we determine that? We intervene with the determinants that first offer us the best chance of success in achieving the desired outcome. Okay? So the determinants that have a greater impact on the problem, and also the determinants for which there are effective interventions. So this goes back to the literature review. Remember I said the second key purpose of the literature review is to identify what effective interventions exist that have been tried and found to work, perhaps in other settings or with similar populations. Okay? Also, resources determine if we can intervene with one determinant or with multiple determinants. If you have funding, for example, multi-million dollars of funding, like in the case of the project that we're working on, the project can seek to impact multiple determinants, because you can have more people working on it, you can have, a greater budget, and vice versa. So really, what determinants you select to intervene with, again, depend on which ones offer you the best chance to succeed, which ones have effective interventions, and the resources that you have available to you. So once you've determined what determinants you want to intervene with, one or more, you need to develop your impact and process objectives. So what are your impact and process objectives? Let's keep this. So we talked earlier about your outcome objective, which addresses the future level of the health problem and is typically long-term. Your impact objective is going to address the future level of the determinant or determinants that you are intervening with, and it's going to be typically intermediate in duration, 1 to 5 years. And then your process objectives are gonna address the future level of the contributing factors, and those are gonna be typically short term. So let's go back to our example here, the very first one. So our outcome objective in this example is gonna be, to reduce neonatal mortality rates in our community or among our priority population from the current level in the baseline year to the future desired level by the end of the intervention time period. In this example, we have to develop, again, an impact objective and process objectives. Your impact objective is going to address the future level of low birth rate in the community. So you're going to want to decrease the low birth rate, okay, again, in your priority population from the current level at baseline to the future level. And your process objectives are going to address your direct contributing factors. So typically you're going to have multiple process objectives. One of them will focus on decreasing tobacco use in pregnancy. So decrease the proportion of pregnant women who use tobacco from the current level to the future level. We're going to have the second process objective focused on low maternal weight gain, which is going to seek to increase the proportion of pregnant women who achieve the recommended weight gain during pregnancy from the current level to the future level. And you're going to have perhaps the third process objective focused on increasing the proportion of pregnant women who start prenatal care during their first trimester from the current baseline level to the future desired level. So again, your process objectives are going to address the future levels of your direct contributing factors. If you achieve those process objectives, that should lead to achieving your impact objective. Again, if you've done your analysis for risk factors accurately. And in turn, achieving your impact objectives should lead to achieving your outcome objective.
So the process objective is being implemented at the community level to affect the direct contributing factors.
Right.
And then impact is at direct to impact determinants. Or am I confusing that?
Yes. Your process objectives, again, are going to address your direct contributing factors. Okay. Then for each process objective, you're going to develop an action plan. The action plan will specify the activities that you have to implement in your community to achieve your process objective. So to decrease the proportion of pregnant women who use tobacco during pregnancy, you're going to have to limit access to tobacco use. You're going to have to implement, one or two different health education programs. You're going to have to implement a tobacco cessation program for pregnant women. So those are going to be your activities or tasks that are going to be included in your action plan for that process objective.
Okay.
And then you're going to develop another action plan for your second process objective. That action plan will include activities related to increasing access to healthy foods and access to the WIC program in your community. Okay, again, in order to achieve your process objective of increasing the proportion of pregnant women who gain the recommended weight gain. Similarly, for your third process objective, focused on prenatal care, you're going to develop an action plan with activities focused on providing transportation to prenatal care providers, for women who do not have transportation, providing daycare services for pregnant women where they can keep their children while they go get their prenatal care, offering them vouchers if they are uninsured so they can get their prenatal care at a lower cost. Those will be the kinds of activities that you will include in your action plan for the process objective focused on prenatal care. Okay? So in this example, your outcome objective is going to address what? In this example, your outcome objective is going to address unintended pregnancy. So your outcome objective will be something like to decrease. Let me ask you this, what proportion of pregnancies in the US are unintended? Do we know? What proportion of pregnancies in the US are unintended, meaning mistimed or unwanted? 45%. You're close. Is the current figure. In the southeast region, it's actually higher. 50% of all pregnancies in the southeast region are unintended. So our outcome objective is going to be to decrease, right, the proportion of unintended pregnancies from 50% to the future desired level, again, particularly among low-income young women, which is our target population. In this example, our impact objective will address the future level of what? Listen, please. Our impact objective will address what? Effective contraception use. Our impact objective will address the future level of the determinant. Okay? So our impact objective will be to increase the proportion of young, low-income women who use effective contraception from the current level to the future level. And our process objectives in this example are going to address what? Access, knowledge, attitudes, and providers. So we will likely have 2 or 3, again, depending on the resources that we have, process objectives. One process objective seeking to increase women's knowledge and attitudes about contraception use. One process objective seeking to increase women's access to contraceptive services. And one process objective seeking to increase the proportion of providers who offer the full range of contraceptive services to their patients.
So would you have 2 impact objectives, or would you choose?
You will have, that's an excellent question. You will have a second impact objective if your intervention is also seeking to address the level of sexual activity in your priority population. So if you're going to be implementing activities to, for example, decrease the level of sexual activity among adolescents, then yes, you would have an impact objective related to sexual activity. But if you're not, if you're not intervening with this determinant, with sexual activity, then there is no need to have an impact objective focused on it. Similarly with the breast cancer, you may intervene with screening or with treatment or with both. So depending on your intervention points, you will have one or more impact objectives. Yes? Yes.
So, will we educate only the women or also the men about it? Because we are talking only about the women.
No, the women and the men in this case, certainly. And the families, if you have the resources, because oftentimes, particularly for teenagers, their access to care, their use of services is also influenced by their mother or their father. Excellent point. Questions? Okay. So you're gonna do this again for your project, folks. You're going to identify your problem, analyze it for your determinants and contributing factors. We're gonna ask you to identify one determinant to intervene with. You will identify two determinants, but you will select one to intervene with, and you will develop an impact objective for that determinant. And then you will identify contributing factors for that determinant and develop two process objectives, if I believe, one for each of the two contributing factors that you decide to intervene with. Okay. So, next week, we're gonna start here. We're gonna basically start discussing work plan, budgets, and evaluation. So during the first hour next week, we're gonna talk about how we translate each process objective into activities and tasks, and we're actually gonna learn how to develop a budget for a program with personnel and non-personnel expenses. And then during the second hour, we're gonna discuss program evaluation, the different types of evaluation designs, and issues related to them. Any questions related to anything that we discussed today? There is no quiz for next week. This is one module, so the quiz that you completed earlier this week covers both weeks, and it's also the same set of readings. Okay. Any questions or final thoughts before we conclude for this afternoon? No? Going once? Going twice? Okay. Thank you, folks. Take care. See you next time.